पानी पिला दे यार। एक मिनट रुक, मैं लिख रहा था। वो नहीं आएंगे क्या? नहीं नहीं। मैं वो खाली पेट्रोल ही कर रही बेटा। यार एक बात बताओ, इसमें पॉइंटर का ही नहीं काम करता है। हाँ, इसमें करेगा। यहाँ नहीं दिखता है ना पॉइंटर। हाँ। यहाँ चाहिए, ये वाला चाहिए। नहीं, यहाँ पर रहेगा तब तो पीछे देखने का, ऐसे ऐसे करके ऐसे बताते वो समझ में नहीं आता। अब पहुंचे तब तो। ऐसे दांत में थोड़ी अलाउ करेंगे। अलाउ। अकेले हो गए। कंटिन्यू ना। योर कीबोर्ड कैन नॉट बी आइडेंटिफाइड। हाँ, दिक्कत वही होता है सर, बोलते हैं कि ये पॉइंटर से बताओ, पॉइंटर तो जब तक पीछे तक। हाँ, अभी कर लिया। वही। हाँ। ठीक 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 ठीक। हाँ, उसको नहीं। हाँ, नहीं आया। जब खुली है बटेटी मतलब अंडी। यस। सर ये वार्ड आईसीयू वाला। हाँ है सर। हाँ, क्या बोल रहे हैं, लाल कलर? यहाँ से पॉइंट रेड कलर, रेड की जगह तो ऑप्शन आ जाता है। रहने दे। रहने दे, आज बात करने की फिर और भाई। भाई पानी मारा भाई। अरे मुंह सूख जाता है मेरा, नहीं पाता इतना लंबा से। हाँ। हाँ, बहुत। हाँ। Good morning, teachers. Today I'm presenting my thesis data on the topic to determine the predictors of reversibility of acute or chronic liver failure at 6 months. This is a prospective study. A necessary ethical approval has been taken, and the study was carried in the Department of Epidemiology. A partial definition for the reversibility. Reversibility defined as a reversal of key component used for defining the syndrome of liver failure, that is the decrease of bilirubin below 5, and reversal of coagulopathy with the INR to come down below 1.5 with no encephalopathy with or without resolution of fasciitis. PASL has the concept of the reversibility, while Western literature still denies for the reversibility in ACLF patients. In the ACLF, patient undergoes the fate of either they had the recovery, either they underwent for the liver transplant, or they don't survive. So the patient who recover, they are either having the cirrhosis with achieving the recompensation, or those who are not having the cirrhosis in fibrosis stage, they can have the reversal with the reversal of the fibrosis. So the reversibility of ACLF pathophysiology involves the mitigation of the acute insult, and over time the hepatic reserve improves. Fibrosis regresses and the portal pressure decreases. Portal hypertension in ACLF. Portal hypertension in ACLF is associated with the structural damage, which is irreversible, while the dynamic component that include the increase in the cytokine production, endothelial dysfunction, impaired vasorelaxation, and impaired vasovascular relaxation may be reversible in the pathophysiology. So this is as per the ARC concession 2019, where among the survivor at the 90-day, the reversal of ACLF syndrome was noted in nearly 70% of the cases, with almost two-thirds of the patient who had the reversal of ACLF syndrome by day 90, so a persistent regression of the disease by 1 year, and reversal of coagulopathy precedes the reversal of jaundice. A higher platelet count, lower leukocyte count, and the absence of HE are the additional independent predictors. So, taking this concept, there Chinese study on the reversibility of the ACLF in hepatitis B population was done with the with the cohort of 1,044 patients having a CTP of 11 and the MELD of 24.8 with MELD sodium of 26. They had the mortality, 28-day mortality was there of 28.2% and 90 days mortality was 40%. They compared the ARC is a partial ACLF and the non-partial ACLF patient and had the 5-year cumulative survival of around 88%, with the patient surviving at the day 90 of 472. They also give the concept of the partial reversal, where the reversal of jaundice and the reversal of INR was seen in about 80% of the patient. So LACMA, for my study, is that although the predictor for the early liver transplant and the survival in ACLF exist, but none reliably predict the reversibility of the ACLF. And there is a need for prospective study to determine the predictors of reversibility as per the Kyoto consensus. So baseline predictors could reliably predict reversibility of ACLF and will help in improve clinical outcome and the risk stratification. Aim of my study is to identify the predictors based on the clinical biochemical parameters and the non-invasive test to reliably predict reversibility of ACLF at 6 months. So primary objective of my study is to determine the predictors based on baseline clinical and biochemical parameters and available non-invasive tests for prediction of reversibility at 6 months in ACLF patients. Secondary objective is to see for the association of baseline ARC with 90-day and 6-month reversibility, association of delta LSM and SSM with 6-month reversibility, association of degree of fibrosis with the 90-day and 6-month mortality reversibility, proportion of patient achieving early reversal, that is at 90 days, and the proportion of patient having survival at 6 months, 1 year, and proportion of patient going for the liver transplant within 1 year. Study was a prospective cohort study done at the Department of Hepatology, and patients were followed for the tenure of 1 year. All patients of ACLF admitted in Department of Hepatology were taken, and the acute insult include the alcoholic hepatitis with hepatitis B reactivation, acute autoimmune hepatitis, viral, HIV, and drug-induced liver injury with the patient of age group of 18 to 70. Those patients having the acute decompensation and having the PVT, SCC, tumoral portal vein thrombus, CKD, and the pregnancy, pregnant female were excluded from the group. So, and the primary endpoint of my study was to see for the reversibility at the 6 month, and the secondary endpoint being the reversibility within 90 days or early reversibility, mortality, or the need of liver transplant. So, study definition includes the acute and chronic liver failure as per APASL definition, that is acute hepatic insult manifesting as a jaundice with bilirubin more than 5 and coagulopathy of INR more than 1.5 or prothrombin activity less than 40%, complicated within 4 weeks by clinical ascites and or encephalopathy in patient with previously diagnosed or undiagnosed CLD, and is associated with a high 28-day mortality. Reversibility is defined as the decrease in the bilirubin less than 5 and INR less than 1.5 with no encephalopathy with or without resolution of ascites at 6 months. Partial reversal is reversibility of the individual parameters. And the sample size were calculated assuming that the expected reversibility of ACLF of 60% and the desired confidence interval of 90% with the alpha power of 5% and precision of 5%. We need to enroll 370 cases, considering 36% of the mortality within 28 days in ACLF patient. We enrolled 480 patients and prospectively followed them for 1 year. We use the continuous data were represented as mean plus minus standard deviation and the median with interquartile range. Those have the skewed distribution. The categorical data were represented as a number with their percentage. Continuous data were compared by student t-test. The chi-square test were used for categorical data comparison, and the log transformation was applied for non-normal data. Univariate and multivariate Cox regression was done, and Kaplan-Meier were used for the prediction of survival. The classification and regression tree analysis were done to find out the tentative cutoff value for the reversibility using the bilirubin and the INR. And the p-value of less than 0.005 was considered significant, and all analysis were done using SPSS 29. So, ACLF patient enrolled, and then the standard of care was given as per the institute protocol. 90-day outcome were monitored, 6-month reversibility were seen, and they were followed up till 1 year. Primary objective and secondary objective were subsequently seen. So we followed the patient for the 1 year time period and having the OPD follow-up at the 1 month, 3 months, 6 months, and 1 year. We had the lab investigation, non-invasive test in form of the FibroScan, and those eligible patients have also undergone for the FUPG and TGLP. So among the baseline characteristics of is the 475 patient, the acute insult is predominated by the alcohol, where the alcoholic hepatitis had the ratio of 75.6%, and chronic also alcohol had a 75.2%, with metabolic having the 12% share. Bilirubin in my group of patients were 23.31 plus minus 8.35, and median was 24.3 with INR of 2.47 plus minus 0.77. So these are other lab parameters.
Don't jump, go back and let people read. What is the INR?
INR is 2.47 plus minus 0.77 in the court. And bilirubin 24.30 median. Ma'am, I have given it subsequently. This for the whole course. Uh, Among the inflammatory markers, PCT, galactomannan, ferritin, CRP, LDH, D-dimer, bile acid, urinary NGAL were followed. Uh, yeah. Oh, okay. Oh, yes, sir. Sir, yes. Sorry. And among the other inflammatory parameters, urinary NGAL, bile acid, D-dimer, LDH, ferritin, PCT, fibrinogen, phosphorus, HDL were noted at MTS, BWF in the subgroup of the patient, and patient having the ICU stay of around 6 to 8 days with the hospital stay of around 2 weeks, that is around 14 days plus minus 8.53, with the MELD of more than 30, 32.83, MELD sodium of 33.39, with the CTP of 11.85 plus minus 1.48. So, in between both group, reversal and the non-reversal group, BMI is a significant factor. With the in the reversal group, it is around 26.06 plus minus 3.11, and in non-reversal, it is around 30 plus minus 3.54. TLC, neutrophil, platelet, as seen in the other study, were significant factors, with the lower TLC, lower neutrophil, and a higher platelet, and the lower bilirubin being seen in the reversal group of the patient. Uh, Among the gender, the male is predominant of around share of around 78 to around 93% in the reversal group, and around the 95% in the non-reversal group. Etiology, again, alcohol is the predominant, and in those patients who have undergone the HPPG, TJLB, or the biopsy-proven fibrosis were seen, were stable patient, and they had the fibrosis F4 staging in the large number of the patient, with the reversal group having the lower percentage with the 50.8%, 62%, 62 patient, and in the non-reversal group it is around 92.3%. Baseline organ failures were the hepatic encephalopathy, pneumonia, shock, AKI. Uh, they are significant, and those requiring the RRT and the ventilator requirement were also significant, in significantly higher in the non-reversal group. Among other baseline characteristics, in the reversal and the non-reversal group, baseline urea, lactate, creatinine, inflammatory markers were significant, and what the time is. HDL was also seen significant, with the higher value in the reversal group and the lower in the non-reversal group. Uh, the liver severity score were higher in non-reversal group, with the 14.05 to 14.04 for the SOFA, RP score being the 12, more than plus minus 1.33, MELD being the 37, plus minus 8.6, and the CLIP C ACLF score is also more than 60, plus minus 9.25 in the non-reversal group. So the proportion of the patient achieving reversal at 180 days among the whole cohort is 208. That is around 43.7% of the patient. And those patients who survive for the 28 days, in those, the reversibility has had a higher number of around 69% with a total number of 193 patients. Patient having the reversibility by the 90 days, showing the 184 in 184 at the 90 days survival. 90 days survival is in the 90 days reversibility was seen in the 184 patient, and maximum patient who has died in the early 28 days. Those didn't survive, but those survived having the reversibility at the 180 days is 184. So there is a mean time to resolution was also calculated, in which we seen that the uh, INR is first to reverse, followed with the bilirubin, and followed by the ascites. And ascites resolution was seen with the amount of or the length of the diuretic being given to the patient. Where we see that the INR usually get resolved by the first one, bilirubin by second, and ascites usually take 3 to 4 months to get reversed. Various severity score were seen for the association where the area under curve has been seen, where arc baseline showed for the 0.732 with the sensitivity of 69 and the specificity of 69.7. Arc day 7 is the good predictor among the other markers. Predictor score, where arc area under the curve is 0.87 and the sensitivity is around 90% with the specificity of 79.5%. CTP and the MELD is MELD sodium, and the MELD has also done well with the area under the curve for the MELD sodium with the 0.831 and specificity with the 88.2% with the value of 29.5. Among the non-invasive tests, the LSM and NSSM with study with the reversibility, and the absolute reduction in the LSM has been seen of around 13% in the reversible group and around 5.39% in the non-reversible group. SSM reduction has been 23.36% in the reversal, and in the non-reversal group it is around 8%. So we have done the CART analysis, where we have seen that for the bilirubin of more than 2.2, there is a high chances of non-reversibility. But with the bilirubin less than 12 milligram, we achieve a reversibility of around 72%. So the cutoff can be the bilirubin of 12 with the INR of 2.2. We have done the univariate analysis where the BMI, hemoglobin, platelet, NLR, creatinine, lactate, sepsis, SBP at the baseline, HDL, phosphorus, fibrinogen, ferritin, and the log of the ferritin and the CRP has came as a significance. Among the multivariate logistic regression, for the ICLF reversal at the day 180, the higher fibrinogen score, higher HDL, has a good predictor with the absence of the baseline HE sepsis shows for the reversibility. This is the Kaplan-Meier survival estimation for the reversal and the non-reversal group, where there the 14% 14% survival has been seen in the non-reversal group, with the 86-88% survival been seen in the reversal group. So I have already discussed for the Chinese study.
Shreyas,
Yes, sir.
what are the causes of death in those who are not surviving?
Sir,
Hold on. At 28 days, the causes of death before 28 days, causes of death after 28 days.
Sir, among the baseline predictor, we have seen that those patients who are having the high inflammatory markers and having the organ failure, more than one organ failure, are having the death within the 28 days, and those surviving after the 28 days. If they get again the
Go to your curve. The curve Kaplan-Meier you were showing. No. Yeah, this one.
So
So
these patients,
even after 28 days, patients were dying. So the causes of death after 28 days and before 28 days.
sir, among the survivors of
Sir is asking about the reason for readmission. Many of these patients got readmitted even after 28 days. So the most common reason for readmission.
among the most of the patient, the AKI along with the sepsis, being
Just analyze it separately. You haven't because they are still dying. One is a reversal of syndrome and one is the death. So they are two separate things. Continue. I didn't want to disturb you. Go ahead.
so this study I have discussed one HDL that is on the hepatitis B ACLF patient, and the other study is the Agia Soteli D et al. That is the cirrhosis of the ACLF patient, where the cohort contained around 200 patients followed up for the 6 months. In that, they see that the time needed to reverse the condition and the survival, and the infection being the most common precipitating factor for the non-reversibility. Those patients on the mechanical ventilation for survival, NLR, and the CLIP-C organ failure score have been studied and showed the positive correlation. So overall, the reversal of ACLF was achieved at 6 months by 43.7% of the patient, and the patient who had transplant-free survival till 28 days had a reversibility of around 70%. The best cutoff for the bilirubin was 12 milligram and the INR of 2.2 seen with the card. And the patient who had 28-day transplant-free survival had significant better clinical outcome. Baseline sepsis, HE in first week, and the low HDL are among the predictors of the non-reversibility. And day 7 arc is an important to determine the reversal in patient. So this is a prospectively enrolled study where the patient followed for the 1 year, and more than 30% of the ICU patients of around 211 patients have been enrolled from the ICU, and the alcohol being the predominant acute insult with many patients steroid ineligible, and they achieved good reversibility in we have achieved good reversibility in those group of the patient.
Any comments on the guide?
Good morning, everyone. Nice shares. It was really very uh, elaborate, and to follow up all these patients for nearly 500 patients. So the main strength was to give the real percentage about how many patients actually they reverse, because in the retrospective data, many of the times because of loss to follow up, the estimate would be less. Also, I believe that because many of the patients were admitted in ICU, so in those patients, since the mortality is high, so the percentage of overall reversal from different cohort will be different. As far as the reason for death, even after achieving reversal, so he has the data for the reason for readmission, and it was seen that patient who achieve reversal of ACLF, there the reason for readmission, those patients, they have very less readmission rate. Even the readmission is required after sometimes 3 or 4 months compared to those who have not achieved. And the most common reason for readmission was either sepsis, worsening of AKI, or variceal bleed. And the main point to highlight was that since alcohol was nearly 70% and many of these patients were steroid eligible, so compared to DILI, AIH, and Hep B reactivation, since these patients were having eligibility for a definitive treatment, so probably that is why we are achieving a good reversal in those subset of patients. So intergroup or even the dominant etiology could be individually assessed in subgroups.
My suggestion is it's a good work. It's a very robust data because someone has followed 475, 500 patients regularly. It's a very robust data and you have wealth of it. But I think it still needs a lot of more analytical questions to be defined. Your questions can certainly be better. For example, those patients who had small varices or no varices, or patients which have You go to LSM, SSM data. Your SD variation is no, यही वाला. इसमें standard deviation
That
is huge. So you can pick up patients who are between, let's say, non-cirrhotic, if you say whether they are worthwhile. Those who have very high LSM, what happens to them? Very high SSM, what happens to them? The patients who have come in different stages, what is their survival? Vis-a-vis not. Maybe those who have no fibrosis have better. Then you have liver biopsy. Probably, so you should try and correlate with biopsy. And also you should use LB score. You should try and see if LB can be of a bigger benefit or not. It's a very robust data. Compliments to both Guide and Shreyas. Any other comments? I can't hear. Yeah.
How you can know? Because SCLF is not a disease for acute, it is a chronic disease. So is reversal a time point and a reversal in per se is has any outcome in long term?
Sir, in those patients having the reversal or having reversal had a less number of the hospital readmission, and also those patient has achieved complete reversal of the disease, and they are almost 30 to 40 patient are such that they are coming for the yearly follow-up. So they are having no symptom related to the liver.
Is the portal hypertension regress? Are other complications less? Survival is one point.
No complication in 30 to 40%. We have
You should, that's an important question. After 6 months, what happens?
Sir,
Yes,
in
obviously someone has a bilirubin low and INR is low, there is reversal. That means it's a good parameter. But it is known to everyone. There's someone having a SCLF, his bilirubin is calmed down and is calmed down. That is okay. But
sir,
as it-
in patient having the infection, whether with have the low bilirubin or a high bilirubin, we have seen in the chart also that if the INR is on a higher side, but if the bilirubin is of the lower, with no infection or a sepsis, in those group of patients, we have seen that they are having the reversal or having the complete resolution of the disease.
So in the previous study, sir, in the hepatitis B patient, those patients were followed for nearly 5 years. So what they said that once after 90 days, these patients still 5 year, they don't have nearly 90% of them, they sustain their reversibility and they don't have liver related outcomes. But at 1 year is a very short time to expect again worsening. So
Oh, yeah. So that's why your reversal should depend three things. One is the infection, one is hepatic reserve, one is severity of injury. If these three things can able to categorize, then study has more impact. Otherwise, simply bilirubin reduction, INF reduction, having a reversibility has no meaning. And second, the most important what is the hepatic reserve long-term outcome. There is no data on long-term outcome of SCLF patients who are recovered. Because if you think of apostle SCLF, it is a hepatic reserve, it is a reversibility, and it's a long-term outcome. These three will make something different. Otherwise, only simply reversibility at 3 months, 6 months is not going to make any good way to go ahead.
Okay. Well, you have achieved your objective, but you should have presented before your exam. But anyway, thank you, Shreya. Thank you, Rajesh.
thank you, sir.
Is there any other presentation? No. Sir. No? No.